Good morning, everybody. I'm Adrienne Jones, Director of Community Health Improvement in the Office of Population Health. And of course, I have the esteemed honor of introducing our speakers for this morning's Grand Rounds. The IPPQ's Grand Rounds grew directly out of our 2022 to 2024 Community Health Implementation Strategy. And so the CHIS really emphasized the need for moving from isolated interventions toward a more integrated trauma-informed approach, especially in our OBGYN settings, where providers honestly really are the first point of disclosure. And so the CUES model, confidentiality, universal education, empowerment, and support, was identified as a promising practice, and which really aligned with a lot of our goals. To really bring this work to life, it's important for me to name my esteemed colleague, Mary Laube, Adult Injury Prevention Coordinator, who partnered with Futures Without Violence, a national leader in trauma-informed and survivor-centered care for more than 30 years. The CUES framework equips providers to engage all patients in brief universal education about healthy relationships, confidentiality, and available supports, and really making that shift from screening to meaningful connection. And so we're honored here to welcome Kelli McIntyre, a consultant for the National Health Resource Center on Domestic Violence and senior consulting partner with Just Strategies. Kelli brings over 20 years of experience leading trauma-informed organizational change and centered health, healing, and justice. Following Kelli, we have Tiffany Garner, federal policy advocate for children and health at Futures Without Violence, who will really help bring us that zoomed out lens of the national policy landscape, really linking this work to violence prevention, maternal health, and survivor-informed advocacy. And so again, welcome our speakers.
Thank you so much, Adrienne, for that introduction. And thank you so much to Jamie and Anu and Mary for all of your work behind the scenes to make this happen today. We're really honored to be here today, Tiffany and I, for this second to last day of Domestic Violence Awareness Month. As Adrienne mentioned, we are here from Futures Without Violence, an almost 40-year-old nonprofit looking to end violence, especially gendered violence against women and girls, with the mission to heal those among us who are traumatized by violence today and create healthy families and communities free of violence tomorrow. It's home to the National Health Resource Center on Domestic Violence, the HRC, who provides training and technical assistance to health providers and advocates to better meet the health needs of survivors. So we'd like to start today with just a little shared understanding and group agreements for our time together in this space. This topic can be heavy, especially for those with lived experience of violence or trauma, or if it's impacted someone that you know. In fact, because of the prevalence of intimate partner violence, we operate with the assumption that there are survivors and probably people who use violence in our shared space today. So it's important that we make room for people to process as you need to. So here are our proposed group agreements. One, we just ask you to take care of yourself and each other. If you feel like you need to stand up, get some water, leave the room, whatever you need to do to take care of yourself, or if you notice a colleague seems to be having trouble, we ask you to just take care of one another. We also ask that if during our question and answer session, people share stories, that we honor confidentiality, that the stories that we hear in the space stay, but the lessons that we learn leave. We also invite you to share your expertise and ask your questions in the chat or during the question and answer period at the end. You feel free to turn on your microphone. And finally, because this is such a heavy topic and we are human beings, we ask that everyone just think about a little self-care plan for yourself for today after the workshop. We know you're going right into clinic, a lot of you, and we'll have a very busy day, but we invite you to just think about a small way that you can make some time to take care of yourself. And with that, we can get started. So our learning objectives for today are to understand the impacts of intimate partner violence on sexual and reproductive health, to define reproductive coercion, to identify some strategies for harm reduction, and to learn the CUES model and how to incorporate it within your practice. Because we are public health professionals and public policy professionals, we're coming to this work with a public health lens. Therefore, our framing is one of health equity. So our definition of health equity is that individuals and communities have equitable access to the things necessary for well-being and self-determination, such that no one's health outcomes are the result of interpersonal or structural oppression. So that approach is both a process and an outcome, which is why it's really essential for us to center the voices and the leadership of the people most impacted, the people that have been historically marginalized, exploited, and oppressed. And we also focus on structural and systems change, thinking systems, policies, environments, and not individual behavior change. So to define intimate partner violence, which I'm sure most of you don't need, but we'll do it anyway. The intimate partner violence or domestic violence comes down to power and control. It's a pattern of behavior that someone uses to gain power and control over another person in an intimate relationship. And people use many different methods of controlling, uh, but they're not limited to physical violence. It's important that we think of intimate partner violence as a pattern because it's not necessarily a one-time incidence of violence, but rather harm and controlling behaviors that the partner is engaging in that can build over time. Some of the methods of intimate partner violence include intimidation, jealousy and isolation, physical violence, of course, sexual violence and coercion, reproductive coercion, economic abuse or achievement sabotage, using your privilege or social capital to force a partner to stay silent or accept abusive treatment, emotional abuse, and also just minimizing, denying, and blaming. So there are so many ways that this issue shows up in relationships, and we want to just keep that in mind. Intimate partner violence is also really complex. For one, addressing violence isn't always the priority. For example, this week, there are a lot of people in our country that are looking at unprecedented food insecurity. So this week may not be the week that folks are interested in addressing the violence in their relationship. Again, abuse happens in cycles, right? So maybe there is a moment or a time period where the partner is loving and caring and not abusive, that then resorts back into violence later on. So it's not always the right time to address violence. We also like to keep in mind that leaving is not always the best or safest option. We know that the most difficult time or most dangerous time for survivors is once they make that decision to leave. Um, we also know that so many survivors don't want the relationship to end, they just want the violence to stop. So self-determination of survivors is really crucial for safety. They know best what they need to stay safe. The person using violence also needs support. So that's one area that we as a society can do a lot better at. We'll mention that a little bit more later. So like we said, intimate partner and sexual violence are really common. Between 1 in 2 and 1 in 5 people in the United States have experienced rape or physical violence or stalking by an intimate partner in their lifetime. So that means, between 20 and 50% of our population. That's a lot, right? And between 1 in 3 and 1 in 4 people have experienced sexual violence during their lifetime. And because of our health equity framing, we understand that intersecting forms of sexism, racism, and other forms of oppression, marginalized and historically exploited people experience higher rates of violence. That doesn't mean that marginalized or historically exploited people are more violent. It is the systems and uh, context that people are living in that make violence more prevalent. We also know that oppression creates health disparities. When it comes to violence, we know that about a little over 43% of Black women have experienced physical violence from an intimate partner, which is significantly higher than the national average of intimate partner violence experienced by women of all races, which is around 25%. Compared with cisgender individuals, transgender individuals were 2.2 times more likely to experience physical intimate partner violence. Poverty and economic insecurity are also barriers for survivors seeking safety. And people with disabilities are significantly more likely to experience all forms of intimate partner violence. And finally, immigrant communities may experience discrimination, stigma, fear of deportation, or the inability to pay for services that make it difficult to seek support. So the health impacts of intimate partner violence and trauma are very well documented. The impacts can be immediate or they can show up much later in life. They can be acute or chronic. And some people are more tuned to their bodies and notice these changes, while others may not be aware of how their body is responding to what they've experienced in their relationships. These are some of the most common health impacts that are documented. We know that survivors are twice as likely to experience a heart attack or stroke, have higher rates of asthma, gastrointestinal issues, sleep and eating issues, chronic pain, and headaches. Brain injury, known as traumatic brain injury, specifically thinking about partner-inflicted traumatic brain injury, is usually a result of strangulation, which is a really common tactic and form of harm used because it's so scary and controlling. Just a few seconds can have a long-lasting impact on mental, cognitive, and physical health. A very short period of strangulation and cutting off oxygen to the brain can have significant impacts on the brain. On average, survivors have been strangled up to 5 times in their lifetime. Oftentimes, strangulation can be done without leaving evidence on the body, and partner-inflicted brain injury survivors rarely receive the proper assessment and treatment. So this might look like memory loss or poor cognitive functioning, for example. So just think about how that might be showing up in your practice. As far as mental health, almost all survivors experience anxiety or depression at some level. They have higher likelihood of experiencing PTSD, low self-esteem, self-harming, or thoughts of suicide. When it comes to behavioral health, substance use is a very common way that people deal with stress and cope with violence and abuse. It's one of the strongest predictors of alcoholism for survivors that are married women. Survivors have a higher likelihood of using sleeping pills or sedatives, antidepressants, or prescription drugs. There's increased heroin use among trafficking survivors and high links between intimate partner violence and opioid use disorders, and higher susceptibility to intimate partner violence when using opioids. Substance use during pregnancy and newborn exposure to substances are a common occurrence in survivors of intimate partner violence, and prominent links between intimate partner violence. There are prominent links between intimate partner violence and substance use coercion. Substance use coercion, which is another practice of power and control over somebody, can look a lot of different ways, whether it's forced to use a substance through violence, abuse, or threats, or manipulation. Forced substance use as a way to exploit someone for their own benefit, for financial gain, like forcing someone to sell or deal drugs or forcing someone to trade sex for drugs or money, also known as sex or human trafficking. Sabotaging a partner's recovery efforts by deliberately keeping substances around them or preventing access to treatment. Substance use coercion can also look like refusing to provide their partner with childcare or transportation needed to participate in substance use treatment. Threatening to inform the authorities like law enforcement or social services or Department of Children and Family Services of the survivor's substance use is also a common tactic of substance use coercion. As for other health impacts on pregnancy, there are many links between intimate partner violence and pregnancy. And 1 in 4 survivors report that their partner was trying to get them pregnant. This is another way someone gains power or control by controlling their reproductive freedom and outcomes. Intimate partner violence increases for unplanned, mistimed, or unwanted pregnancy. And pregnancy significantly increases the risk for intimate partner violence. As for sexual and reproductive health, there's a higher chance of abnormal Pap tests, certain gynecological cancers, sexually transmitted infections, and HIV, vaginal infections and reproductive coercion, and controlling the outcomes of pregnancy and interfering with the proper use of contraceptives. So when it comes to perinatal health, poor pregnancy and birth outcomes have a lot of impacts on fetal development, much higher likelihood of perinatal depression, other mental health conditions, and barriers in bonding with the baby. As for maternal mortality, intimate partner violence is a major contributor of maternal mortality due to high rates of homicide, suicide, substance use disorder, and overdose. And early exposures to intimate partner violence, like childhood exposure, increases your risk for adverse childhood experiences, ACEs, and may contribute to health issues, behavioral issues, and academic performance issues. So there are so many ways that relationships can impact our health. I just want to be keeping all of these in mind as we think about the survivors that we might be serving. Barriers to care. Intimate partner violence prevents access to care for so many reasons. 17% of cisgendered survivors report that their partner prevented them from accessing health care. And in a 2021 national hotline study during the COVID-19 pandemic, 53% reported that a partner who chooses to abuse has also controlled or restricted their access to health care. And why are some of the reasons that this might be? It might be that abusive partners restrict access to financial resources or insurance or medical or mental health care. They withhold transportation or child care so that the survivor can't get to a healthcare setting. They may manipulate or cancel appointments. They may engage in stalking. And they may try to align with providers to discredit survivors, controlling medical decision making and limiting the survivor speaking during visits. It's important that we recognize the signs that there may be an indicator of intimate partner violence, and it's also important to recognize that oftentimes survivors haven't seen a healthcare provider or access routine preventative care in a long time outside of emergency visits due to injuries. They may prioritize care for their children over themselves. There's less of an opportunity for early detection of issues, and we want to keep this in mind when working with a patient who is really behind on recommended preventative screenings, or maybe could have prevented a condition from worsening. We also want to check our biases around instances like this and work toward letting go of any judgment we might have about a person because of this, and instead passionately inquire about what may be going on that's getting in the way of them accessing important care for themselves or children. Ultimately, we want to rethink noncompliance. Lastly, recognizing that healthcare workforce stigma, judgment from healthcare providers, and shame that's experienced by survivors also contribute to the barriers in accessing care, and also just seeking help generally. And with that, I'm going to pass this over to Tiffany so you guys can stop hearing me so much.
You are totally fine, my friend. Hello, everybody. I'm just jumping in. It's so good to join and continue on this conversation around the importance of, as you all prepare to engage with clients and honestly patients, and honestly, you all, as I'm just kind of listening to my partner here, I'm just thinking too. I used to be a mental health a practitioner, and I think about the impacts on. You just said, Kelly, about children and how oftentimes survivors will prioritize their children before their own needs. And oftentimes we see so many children who are impacted by the level of exposure that sometimes it could be evident physically and not. So, this is just so deep. So hopefully this is helpful to you all listening. So just continue on this thought process around rethinking non-compliance when it comes to survivors who may come to your practice or those you may engage with. Women, we'll say people in general, but as we're just kind of continue on this conversation, women experiencing IPV are twice as likely not to initiate prenatal care. So looking at those who may be, who may come to your practice and they are expecting and pregnant, sometimes we find cases because IPV is present in their situation, they may not initiate that appointment or those visits until third trimester. Why? Because you don't know what's happening in relationship. There's lots of controlling tactics. Also, maybe some barriers to how they even are able to even seek care. Especially, I've seen a lot of women who may not financially have the resources, or they may be dependent upon their partner for the financial ability, insurance, those type of things to be able to engage. So it might not be until later on. Also, you're thinking about where you practice too. If you are in more of a urban community versus more suburban, rural areas, some of those other barriers, depending on where you are located, that may also interfere. Transportation, how people get there. So we kind of look at it from a little bit more of a not just IPV, but social determinants of health too. How some of the barriers that why pregnant women, those involved in IPV, may be delayed, but not just pregnant women. So you also see our other stat here. Women who are significantly more likely to miss 3 or more prenatal visits than their non-abused counterparts. So again, just kind of coupling into some of the dynamics that might be happening in an IPV relationship that may cause them not to be able to engage, not necessarily because they don't want to, but maybe there are some other components. But not just for those who are expecting and pregnant, we also may see patients who are just in unhealthy relationships. They may not be able to make their own decisions in the relationship. Health conditions, maybe some chronic conditions that they already have, make it harder to manage. And from some of our worldview, it might be like, well, wouldn't that make sense for them to be able to come in because they have challenges? Well, there again, some of the barriers that Kelly mentioned earlier. If you have a questionable immigration status, or you may not have the finances and transportation, and you might be in an unsafe a very super controlling situation, you can't make it. So these are some other things that we see that we are trying to encourage providers to rethink how you think, oh my gosh, these are just non-compliant patients. Like, what in the world? Let's maybe take a step back and really look at the full picture, what that person may be going through before we completely, dismiss them maybe mentally, and maybe check some of our own biases as to what may be happening in this case. Missed appointments, patient may not be able to adhere to the care plans. Let's just start first asking, what's happening in this situation? Because also there's an element of trauma that a lot of people carry. And trauma is just your response to, overwhelming situations. Sometimes when people are going through those experiences and those emotions and processing, they are unable to engage the way we would like them to. So let's just remember to approach this word from a trauma-informed lens and understand people may not be able, but let's ask the question, what's happening, before we just completely just judge them as non-compliant and be dismissive. Not that that's any of you all, but I'm just saying. So we can go to the next slide, Kelly. Are you gonna keep rolling, or you want to hop on?
I can hop back in for
hop
a
on.
moment and then pass it back to you.
Yeah.
We want to make sure I'm keeping an eye on time. We have so much content and so little time together. This could be a 3-day training, but we're going to do it in 50 minutes, right? But we definitely want to cover some of the intersections between intimate partner violence and sexual and reproductive health, right? Whether they be unplanned or mistimed or unintended pregnancies, pelvic pain and infections, sexually transmitted infections, preterm birth and low birth rate, all of these outcomes are connected directly to intimate partner violence, and they kind of operate like a little cycle. Intimate partner violence can increase experiences of pelvic pain, STIs, etc. And those things can actually increase experiences of intimate partner violence. When it comes to reproductive coercion, it's such an important topic, which is when people, abusive partners, exert power and control over the other person's sexual and reproductive health decisions. That may look like pressuring someone or trying to get someone pregnant when they don't want to be, controlling the outcome of a pregnancy, either forcing an abortion when the survivor may not want it. It may be interfering with proper use of birth control, forcing sex or other certain sexual activities, threatening to disclose STI status, or forcing people to have sex with others for their own gain. We mentioned that earlier. So in this study that was done by the National Domestic Violence Hotline, 63% said that their current or former partner pressured or forced them into having sex. So that's a lot of people, a lot of survivors that describe reproductive coercion as one of the tactics of abuse that we want to make sure we're keeping top of mind. So reproductive coercion can again include things like tampering with birth control methods, or selfing, which is removing the condom without your partner's consent, tracking periods to determine when the partner will be most fertile, or coercing unprotected sex. Here is a quote from a survivor that is published in a study by Beth Miller and folks over at Pitt. And it says, like the first couple of times, the condom seemed to break every time, you know what I mean? And it was just kind of funny, like the first 6 times the condom broke, 6 times, that's kind of rare. I could understand 1, but 6 times? But then after that, when I got on birth control, he was just like always saying like, you should have my baby, you should have my daughter, you should have my kid. So this is one of the ways that reproductive coercion might show up for a survivor. And I'll toss it back to you, Tiffany.
Yes. All right. Well, continuing on, I know you all have heard us kind of thread in this whole thing around domestic violence and pregnancy. Just continue harping on, because number one, this is an area that I spend a lot of time focusing on, not just in our work here on our health center work, but also in our policy world too. So yeah, trying to see, again, it's such a sacred time in a person's life, and we've seen so absolutely devastating cases of violence and mortality, right? So anyway, so continuing on here, and just a couple stats for you all. I'll breeze through a few of these because I want to be mindful of our time. I know we got to get to some other info for you all, but DV in pregnancy, so women experiencing physical abuse around the time of pregnancy are at an increased likelihood to cease breastfeeding by 4 weeks postpartum. So again, we look at not just pregnancy, but we also look at what's happening to women what postpartum. You know, maybe you all have heard some of the stats around some of the most dangerous times is when a woman is pregnant and postpartum for risk of homicide. And so that also fuels the current maternal mortality, well, a portion of the current maternal mortality crisis is looking at what's happening around this and the homicide rates of women. So this is some very tender times, but we also, like I said, our lens is looking at what's happening when you have increased levels of the physical abuse, what it happens to the mom and then the baby too. And so mom maybe experiencing controlling, threatening partner are 5 times more likely to experience persistent symptoms of postpartum depression. And this is also where we kind of see some women who may choose to use substances as a coping. Maybe they were using substances before as a coping mechanism to deal with their relationship. That's also a thing we also have to think about when it comes to times where we see women who are birthing who may use substances after the baby's born. Mom may test positive for substance use in her system, in the baby system. And it's unfortunately in our system, and I totally get this, but you know, it oftentimes can flag a child welfare call and get more system involvement than maybe what's necessary, because maybe that's a time for us to stop and say, hey, again, what's really happening in this situation? Because biases can come and say, oh, she's just, you know, addictive and all the things that we can label people instead of saying, well, why is she using? What happened? And oftentimes we see that as an opportunity for that mother to have a form and a method of escapism as they're dealing with a violent and abusive relationship. That also can flag the question, why don't you just leave this person? Again, very complicated situations, but I'm just letting you know some of the things that can swirl in our minds as providers and practitioners as we are looking at presenting symptoms of depression and what may couple with that too. Also, we see rates of suicide that can happen, right? For mom, when it has postpartum, suicide can result to, again, that may be, you know, due to what's happened to her hormonal levels, but that also may have something else happening. Maybe there is a violent situation or an abusive relationship that that person's into. So lots of layers to dig in as we look at people and people that may come before us as we provide services. Next slide. Okay, so just continuing on, these are just a couple snapshots. Again, physical DD 12 months prior to pregnancy increases your chance that when you are pregnant, have high blood pressure, vaginal bleeding, severe nausea, vomiting, placental abruption, preterm birth, and of course, even after baby's born, we may see baby come out with, next slide too, low birth weight or some of the lower birth, more poor birth outcomes than we desire. When I used to work as a clinician, I used to train community members on what happens to women when to their baby due to the biochemical connection of the baby in utero and once the baby was born. Plenty of babies are born and they are, of course, as we're concerned about mom's health, we also look at babies who are more colicky, maybe have troubles with some of their first, initial developmental stages too. So all these could be a factor in looking at what has happened as a result of an IPV relationship, right, on mom and baby. So we just want to make sure we showed you all, these are some things that could happen. That is not every case, but these are some possibilities when you have the presentation of IPV in a situation. Next slide. All right, so I just want to add it to you all, this conversation just briefly around firearm violence. So everyone, I hope all of us know on this call that firearms or gun violence, however you want to say it, is preventable. If I was with you all, I would like, let's say it together, it's preventable, because my goodness, it is so pervasive in our country, a major, massive public health crisis that we really could avoid, but that's a whole nother conversation. Couple stats here for you all. A lot of the reports came out. These are some John Hopkins and Giffords. Giffords is an organization founded by a former Congresswoman, Gabby Giffords. I used to work for her. So I was like, let me just throw in some stats too, because they always present some really good data. So does Everytown, so does Brady. We have a lot of great gun violence partners. But just want to say this, in 2023, just looking at these stats, over 46,000 firearm related deaths, averaging 1 every 11 minutes. My gosh, that's a lot of people, right? Of course, I'm scared to see some of the, when they send out the 2024 stats, which should be out soon. But these are what we're looking at as far as in our nation. I want to just give an overview. Gun violence, gun suicide is the most common intent, followed by homicide rates. The United States, we have right now over 400 million guns. That's more guns than people. Okay, that's not alarming by itself. And then also we're looking at rates. Young people, 18 to 29, are most susceptible to homicide, while those over the age of 7, and they experience the highest rates of suicide. Why are we talking about this? Because a lot of folks that are experiencing gun violence, you may encounter them, right? Either this is cases where they may present some of these symptoms before symptoms, as in they may be going through health challenges, and they may come from environments and relationships and situations that may later on lead to firearm violence. These stats couple in IPV as well as so many other gun violence rates. So that's why I'm saying you just never know who you can come in contact with. Next slide, Kelly. I also want to just do a quick little snapshot on firearm violence in Wisconsin. Also just highlighting that not only just the physical harm that we're seeing in our country, and these are some ways that not only just for your own awareness, but ways that possibly as they intersect with IPV, as patients may come to your office, all these things that you can provide resources is what we'll get to in just a second, that we can prevent further extreme cases, such as what we're seeing with the rise in homicide rates. But just in Wisconsin, first of all, I just want to add another national stat around economic costs of firearm violence, around $557 billion a year, which is very alarming because these are a great chunk of healthcare costs. Wisconsin, you know, is working. We're getting there in Wisconsin. I was given a C on some gun violence scorecards from Giffords. There were some estimates that showed around 741 people died from gun violence in Wisconsin. Again, that groups in IPV and homicides and just a wide variety. And Wisconsin has some areas to improve upon to increase the safety of the people in your state. Just a couple of things: background checks, community violence and prevention intervention programs, and extreme risk protection orders. These are just a couple of things that's happened as a snapshot in Wisconsin. But as it relates, Kelly, next slide, to IPV and firearms, just wanted to make sure you guys know, I'll just highlight just a couple here. Over half of all intimate partner homicides are committed with firearms. Again, this is why we're bringing this before you, just to give a global snapshot of what's happening overall. And then in a lot of our intimate partner homicide, in intimate partner relationships, homicides are happening because of guns, because it is so accessible to get guns, whether legally or illegally. And so we want to make sure, again, you just never know who you may come in contact with, that you may have an opportunity. This is not putting it on your shoulders, but you may have opportunity to share a safety resource so that people can seek opportunities for help before it gets to these levels. A woman is 5 times more likely to be murdered when her abuser has access to a gun. So just a couple of things to keep in mind. You all will have these stats, but just, you know, just keep this very stark, these stark numbers in our heads as we continue to provide care. Next slide. Homicides and suicides during pregnancy. Again, just want to kind of wrap this part up. Is homicide is a leading cause of injury-related deaths amongst pregnant women. I'm highlighted this stat. This came from Harvard T. School of Public Health. They've been doing a lot of work prior to a lot of the NIH and all the other public health funding cuts, but they were really one of the universities that was on a path of studying the interplay of firearms and maternal mortality. But I just wanted to just leave this slide with you, this quote with you all on this slide here. Women in the U.S. who are pregnant or have recently given birth are more likely to be murdered than to die from obstetric causes. And these homicides are linked to a deadly mix of intimate partner violence and firearms. So hopefully we'll continue to get more studies as to why we need to pay attention to these intersections and how oftentimes you all, healthcare providers, mental health professionals, we could be those touch points before it gets to these critical cases where we see the rise in mortality rates. Next slide. I'll just share this with you all here really super quickly. IPV homicides in Wisconsin. I've kind of alluded to the fact firearms are common means. These are some stats from 2022. Firearms were the weapons used in 88% of your domestic violence deaths in your state. That's an increase since 21. That's very alarming for the state of Wisconsin. DV assaults involving a gun are 12 times more likely to result in death than those involving other weapons of bodily force. So, you know, we just think about, again, what's happening nationally, but also looking at what's happening in your state. Are there opportunities that not just to provide care, but possibly, I'm just going to weave in some advocacy piece here. Maybe there's room for medical providers and healthcare providers to lend voice to laws and policies that will actually help reduce a lot of the mortality rates or increase the safety rates within your own state. So just wanted to make sure you all had this information to get a glimpse at what's happening at home in your neighborhoods and your communities. Next, Kelly.
Yeah, I'll take over from here.
Mhm.
And I'm going to speed through a little bit of this because we want to get to cues, right?
Yes.
So we'll just touch on the racial disparities in intimate partner violence and maternal health. We know that Black women are 3 to 4 times more likely to die from pregnancy-related causes than white women, and disproportionately affected by pregnancy-associated death by homicide than white women. Um, and Black women also experience pregnancy-associated intimate partner homicide at a rate 8 times greater than their non-pregnant peers, which is alarming to me. It just speaks to the importance of really thinking about these intersections of racism, intimate partner violence, and maternal health. All right. Okay, so we're going to improve our survivor-centered response to intimate partner violence. I'm going to skip through some of this. Uh, we know that many people use screening tools, right, for violence and trauma. And we just want people to think about what's the purpose of using a screening tool? Are you doing it because this is what you have to do? Is it about data collection? Are you trying to get a disclosure from your patients? Or is it about knowing what's happening with them? Like, what is the purpose and the end goal of a screening tool? So often this tool the screening process can look like, so no one's hurting you at home, right? As the partner is sitting right next to them. Or within the last year, has your partner ever hurt you, hit you? Have you been kicked, slapped, punched, blah, blah, blah? With our backs turned or our faces in the computer, right? Or I'm really sorry I have to ask you these questions. It's a requirement, right? Just imagine if you were a survivor and you need help, and this was the approach to screening that you got from your healthcare provider. Would you feel compelled to ask for help? I don't think so, right? So this is the heart of being healing centered and the challenges of disclosure driven practice. Do we really need to know what's happening to our patients to offer them help? And how are we making sure that survivors who don't exhibit red flags or choose not to disclose abuse still get the support they need? Enter CUES. CUES stands for confidentiality, universal education, and support. We want to make sure everybody's familiar with CUES. It's sort of the future's universal education approach for health staff and domestic violence advocates to begin talking about the intersection of health, domestic violence, and relationships with patients and clients. The C stands for confidentiality, which really asks you to first disclose the limits of your confidentiality. So familiarize yourself with what your mandatory reporting laws in your state require you to report. Disclose those limits before the conversation. And confidentiality also means making sure that you see the patient alone for at least a portion of the visit. Universal education is just normalizing the activity of talking to patients about relationships and making the connection between their health and or their visit and their relationships. And finally, the S is for support, which is to affirm the survivor and support them and offer a warm referral or a referral to support services. Remember, patients may or may not disclose, and with CUES, disclosure is not the goal. So some of the evidence behind CUES, here's some of the basics. We know you're doctors, right? So what the original study was a randomized controlled trial with over 1,600 patients in a family planning and a school-based clinic. And the methods were to shift from screening to a universal education method, to use harm reduction strategies for reproductive coercion, including offering copper teas or IUDs with strings cut, or providing multiple doses of emergency contraception or birth control pill management, and also creating partnerships with local domestic violence agencies. We're aware that you all have Unidos and Days in Madison. We're hopeful that this will inspire you to think about, if you haven't already, making connections with those local programs, so that you can make that warm handoff if someone has a disclosure. And this model really can be replicated or adapted for home visitation, for adolescent health, primary care, and other health and social service settings. I'm going to skip right through because, so we can go to this and go to Tiffany. We have, how much time do we have? 2 minutes?
No. So maybe we'll just, go through this as quickly as possible, and then make sure we yield to you all to maybe just to open up for questions, if that's okay with you, Kelli.
Sure. I don't know if we'll have time for questions anymore either, but.
Okay. All right. Well, that's okay. We would maybe some of you all can put your questions in the chat if you have something for us, or Jamie, maybe we can lean on you to maybe field some questions for us. But let's just go through a couple of these, just really be a little bit more in depth. Confidentiality. I think Kelli, you already alluded to making sure that we understand, that you all understand your state's reporting requirements. But I also want to make sure that when we talk about confidentiality and the ways that we approach it, that we also use a culturally competent lens too, and making sure that we understand that when we're talking and engaging with people, that we are clear that what stays within, within the parameters of what you can hold on to, that you do that. So maybe some questions is, before I get started, look at this quote here. I want you to know that I cannot share anything outside of what we talk about today, unless, whatever. So these are just some sample quotes that you all can use and models of what you can use as you engage. I think it's important too, that when I mentioned the culturally competent piece, that we talk to people, especially if you're dealing with people from other backgrounds, that we explain what confidentiality really is, to make sure that people have the clarity, because I get the mandated reporting requirements and all that, but people may not understand what confidentiality really looks like in practice. So I think that that's important to make sure we say, as well as we think about this step. Next slide, Kelli. Unless you wanted to add anything else.
No.
Okay, next slide. Okay, so next you also C for confidentiality, universal education empowerment, such an important part of the conversation. Ways that you can engage this is to make sure that when you're talking to your patients, you let them know that I talk to all of our patients about this, so that they do not feel targeted. They don't feel like you're just talking to them. Maybe you suspected something about them. So to normalize, this is something I want to make sure that all my patients understand, because I know how relationships can be complicated and challenging, but I want to make sure that you have this information. Always make sure you have 2 copies of our safety card. We had a slide. Hopefully some of you all maybe have seen the safety cards. If not, then we are always able to ship some to you, so that you always have copies available in your practice. One that you give to your patient, and then the other one you give to them to say, hey, if this is not for you, this could be for somebody else in your community that you can share this resource to. And then also making sure we have a connection in mind, connect the reason for this visit or the symptoms, as we've already discussed, and talk about, again, making sure you're educated about the connection between relationship abuse and your health. Educate how relationships can impact your health, not necessarily having them disclose what's happening or forcing them to make that connection, but you're just saying how it does, and then supporting the harm reduction portion of it. And Kelli, I'm gonna give you the support piece to you.
Okay. And finally, the last S is support. Offering first gratitude. Thank you so much for sharing this with me. I know it must not have been easy. Making sure that you document the abuse and inform your patient what you're putting into the record, right? So they know what their partner may have access to. And then again, making that warm referral to local domestic and sexual violence advocacy services. So we're making this big to-do about this intervention, which is essentially a 30-minute conversation between you and your patients about healthy relationships. that is supported with these safety cards, right? I'm going to go backwards. So we have lots of different safety cards for lots of different populations. Like Tiffany said, you can get them for free on the Future store. You just pay for shipping. And again, you can order hundreds of them so that you can give every single patient 2 of them. You have this conversation with every single patient about how their relationship can impact their health. On the back of the safety cards are the the numbers for the National Domestic Violence Hotline and other support services. You can even customize this card in partnership with Futures to include your local resources. So if that's something of interest, maybe that's a good follow-up for us.
Yeah.
And I know we're at time, so I'm going to pause for a second and look to Adrian to see if we are able to, do we need to stop now? Can we do a little more?
That would actually be Jamie who would have to make that call because she's in the room.
Okay. Oh, Jamie.
Unfortunately, we do have to stop. And I'm echoing.
Okay. Okay. So let's end with this. Your role is important. Providers, you have an opportunity to offer harm reduction. You have an opportunity to introduce people to this idea of the intersection of their relationship and health. And you have the opportunity to be a trusted partner to help support these survivors to get the help they need. So we hope that this is helpful, an approach for you to think about. If you'd like to have more training on this or talk deeper, we'd love to talk some more. We'll share links and slides after this session. And we thank you so much for taking the time this morning on this early, it's a rainy morning in Philadelphia, but thank you so much for joining us this morning. Tiffany, you have anything?
Yeah, no, this has been great. Like, yeah, echoing same sentiments. Thank you all so much for your time.
So sorry.
Thank you so much for being here with us.